Good morning, all of you. First, I would like to give special thanks to organizing committee, especially Professor Dr. Vitul Gupta sir, who invite me and gave me opportunity to speak on such an important topic, that is rational use of blood and blood products. Now, the concept behind the rational use of blood is we have to use right product in right dose at right time and for the right reason. Why this is important? Because there is a big demand and supply gap. Annual requirement of blood in our country is 14.6 million unit, despite collecting approximately 12 million unit annually. So we are facing a shortfall of around 1 million unit every year. To fulfill this deficiency, we have to adopt some strategy. First and most important thing is we always use blood component therapy. We adopt transfusion avoidance strategy, avoidance of fresh blood transfusion, avoidance of single unit transfusion. We promote autologous blood transfusion, especially in elective surgical cases. We should increase the use of erythropoietin, iron and vitamin B12 replacement to increase the hemoglobin level, and use of vitamin K rather than FFP to correct altered prothrombin time. When we centrifuge the whole blood, it separated into packed red cell, platelet, fresh frozen plasma, cryoprecipitate and granulocyte. By this separation technique, we can provide optimum survival of each component, and we can allow transfusing only specific component that patient require and avoid use of unnecessary component. With 1 unit of whole blood, it can be useful to multiple patients. Indication of a specific component for whole blood. Nowadays, there are no absolute indication for whole blood transfusion, but we can use in case of blood loss with hypovolemia, in exchange transfusion in sickle cell disease and hemolytic disease of neonates. We use PRBC transfusion in symptomatic anemia, and with 1 unit of PRBC transfusion, there will be raise of hemoglobin by 1 gram%. We use platelet for prevention and treatment of bleeding due to thrombocytopenia or platelet dysfunction. We use FFP for replacement of multiple coagulation factor deficiency in case of liver disease, warfarin toxicity, depletion of coagulation factor in large volume transfusion, in disseminated intravascular coagulation and thrombotic thrombocytopenic purpura. Indication for cryoprecipitate, it is used as an alternative treatment of inherited deficiency of one Willebrand factor, factor 8 deficiency, factor 13 deficiency, and it is also used as a source of fibrinogen in acquired coagulopathy like DIC. Now first I will take the PRBC transfusion. So in our clinical practice, how we take decision regarding PRBC transfusion? Is hemoglobin only the deciding factor? No. Hemoglobin value should not be only deciding factor for PRBC transfusion. First we have to assess the patient clinically and think, is it really indicated? We should not transfuse if there is an alternative available. Benefit must outweigh the risk of the transfusion. It is likely to be inappropriate if hemoglobin is more than 10 gram%. It is usually indicated if hemoglobin is less than 7 gram%, and if the hemoglobin between 7 to 10 gram%, then clinical condition must be correlated. According to the International Transfusion Guideline, they recommend if the patient is hemodynamically stable, then cut point of PRBC transfusion is 7 gram%. If the patient have cardiovascular intervention, then cut point is 7.5 gram%, and if the patient have intra-abdominal surgery, then cut point of hemoglobin for PRBC transfusion is 8 gram%. This is common query which we face. Can we give IV fluid with blood transfusion? Only isotonic saline is recommended to use with blood component. We should not use 5% dextrose or ringer lactate solution with blood, because dextrose will cause hemolysis of the RBC and ringer lactate will cause clot formation. So before transfusing the blood component, we should completely flush out all the incompatible IV fluid and drugs, or preferably change the IV set. Another important query, do we need to warm blood? No. There is no evidence of warming blood is beneficial to the patient when transfusion is slow. But when transfusion is very massive and fast, then cold blood may cause cardiac arrest. Keeping the patient warm is probably more important than warming the blood. So warming blood required in large volume rapid transfusion, exchange transfusion in infants, and patient with clinically significant cold agglutinin. When warming is required, the blood should be warmed in blood warmer, and that blood warmer should have visible thermometer and audible warning alarm. Blood should never be warmed in bowl of hot water, because it will cause hemolysis of red blood cells that become life-threatening when transfused. Now, which blood is safe? One from unknown donor or one from family members? Transfusion from first degree relative should be avoided to prevent transfusion associated graft versus host disease. Though it is a rare complication, but it is life threatening. There are few conditions in which we can avoid PRBC transfusion even if the hemoglobin is low. These are iron deficiency anemia, so we should give IV injectable iron rather than PRBC transfusion, vitamin B12 deficiency anemia, and autoimmune hemolytic anemia. Now there is always debate on 1 unit of whole blood versus PRBC, which is better. PRBC always better than the whole blood because it contains 40% more RBC. With whole blood, it is available in volume 350 to 450 ml, so there will be high chance of volume overload. ABO antibodies are more, so there will be more allergic reaction, more transfusion reaction, and there will be wastage of other component. With PRBC, it is available in 200 to 240 ml, so chances of volume overload will be less. ABO antibodies are less, so there will be less allergic reaction, less transfusion reaction, and there will be no wastage of other component. So always you use PRBC in spite of whole blood. Second important component is the platelet transfusion. They are available in two forms, random donor platelet and single donor platelet. Random donor platelet available in 50 to 70 ml per unit. With this, there will be increase of 5 to 10,000 platelet per unit. The dose for adult 6 unit, dose for infant 1 unit per 10 kg body weight. Number of donor exposure are more with RDP, near about 6 to 7 donor required, and ABO compatibility play minor role in platelet transfusion. For SDP, it is available in 300 to 350 ml per unit, and there will be increase of 30 to 50,000 platelet per unit. Dose for adult 1 unit, dose for children 10 cc per kg body weight. Number of donor exposure usually single, so there will be less chance of transfusion reaction, less HLA, alloimmunization, and less chance of transfusion transmitted CMV infection. This is very important. Cut point for platelet transfusion. In any patient who is prone for bleeding, the cut point for platelet transfusion is below 10,000. If the patient have fever, sepsis, and the patient is on amphotericin B therapy, then cut point for platelet transfusion is less than 20,000. If the patient undergo intra-abdominal surgery, then cut point is 50,000. If the patient have epidural anesthesia, then cut point is 80,000. And if the patient undergo neurosurgical procedure, then cut point is less than 1 lakh. If the patient have bleeding that is due to thrombocytopenia, that at any point, that in any platelet count, we have to transfuse platelet. Now this is very commonly faced clinical situation. A dengue patient with platelet count of 10,000 in a peripheral hospital where arrangement of component separation not available, will you ask for fresh whole blood? No. The whole blood transfusion is generally not recommended for dengue thrombocytopenia because it may complicate patient due to fluid overload, transmission of infections, transfusion reaction like urticaria or anaphylaxis, or whole blood has slower platelet recovery rate. So rather than transfusing whole blood, we have to refer patient immediately to higher center where the separation facilities are available. Another important clinical scenario, a 11-year-old child diagnosed as idiopathic thrombocytopenic purpura 1 year back, who is responded well with therapy. He complained sudden onset of gum bleeding and platelet count was found to be 15,000. Whether platelet transfusion will control the bleeding? Again, no. There are relative contraindication of platelet transfusion. These are heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, and idiopathic thrombocytopenic purpura. In these conditions, we should avoid platelet transfusion and we should give definite therapy. Next important component is the fresh frozen plasma. It is available in 200 to 250 ml package and it contains plasma protein and stable coagulation factors. All coagulation factors are available at the level of 1 international unit per ml of FFP, and we can store FFP up to 1 year in below 18-degree temperature. Once thawed, it should not be refrozen, and thawed FFP is stored in 1 to 6 degrees centigrade and transfused within 24 hours. So we use the fresh frozen plasma in coagulation factor deficiency, in disseminated intravascular coagulation, in warfarin toxicity, dilutional coagulopathy in case of massive transfusion, hemorrhage in liver disease, and thrombotic thrombocytopenic purpura. The dose is 15 ml per kg body weight. It should be ABO compatible, but any RH group may be given, and it should not be used for correction of hypovolemia or hypoalbuminemia. Another important component is the cryoprecipitate. It is prepared from FFP, thawed at 4 degrees centigrade and refrozen. It contains more than 80 international unit factor 8, 150 to 250 milligram fibrinogen, 30 to 50 milligram fibronectin, 40 to 70 milligram 40 to 70% bond Bilbrand factor and 30% factor 13. It is available in 5 to 15 ml package and it is stored in minus 18 degrees centigrade and must be thawed before transfusion. So primarily it is used to control bleeding associated with fibrinogen deficiency and to treat factor 13 deficiency. It is used as second line therapy for von Willebrand disease and hemophilia A. It is used to control active bleeding in uremic patient. It is also used in DIC when fibrinogen level less than 100 milligram per deciliter. Because it is small, it is available in a small volume in each unit, so ABO compatibility not needed. Again, it is a very important clinical scenario. A young boy who have transfusion dependent beta thalassemia and started blood transfusion at the age of 2 years and survival depend on blood transfusion. What precaution we have to take for such type of patient and why? So we have to go for extended red cell antigen typing and we try to use leukodepleted blood for prevention of alloimmunization, febrile non-hemolytic transfusion reaction and transfusion transmitted CMV infection. So we always use leukodepleted blood when there is a chronic blood transfusion. Another important clinical scenario, a 45-year-old male patient diagnosed as chronic lymphoid leukemia and received first cycle of chemotherapy, that is fludarabine, cyclophosphamide and rituximab regime. Few days after the chemotherapy, he developed pallor and given 2 units of PRBC. Patient developed post-transfusion fever, diarrhea, skin rash, hepatic failure and expired. What was the cause of death in such patient? It may be a case of transfusion-associated graft versus host disease. In this complication, mortality is very high, more than 80%. Because patient received fludarabine-based therapy, so he should have received irradiated blood product. So use of irradiated blood product to prevent transfusion-associated graft versus host disease. And in this technique, we give minimum dose of up to 25 grays of irradiation, and all cellular components require irradiation except FFP and cryoprecipitate. Indication for use of irradiated blood component are intrauterine transfusion, neonatal exchange transfusion, primary immunodeficiency syndromes, Hodgkin's lymphoma, and patient treated with purine analog drugs like fludarabine. So in all immunocompromised patient, we should give irradiated blood component. While transfusion the blood, we have to take following precautions. Blood component should be checked and matched with patient detail at bedside before transfusion. All transfusions should get completed within a specific time. For platelet, infusion start within 30 minutes and should complete within 4 hours. For platelet, infusion start immediately and should complete within 20 minutes. For FFP, infusion start within 30 minutes and completed within 20 minutes. Routine pre-medication is not required in all patients. Electrotransfusion preferably should be done during daytime, and only fluid which is compatible with blood is normal saline. So take home message, think before transfuse. Does your patient really need blood? Choose the right component, weigh up the benefit versus risk of the transfusion, and do not transfuse if there is an alternative available. So this is my last message. Donate blood and save a life. Thank you.